Hi, I'm Linda Smith, the Executive Director of the Intervention Project for Nurses. I'm glad to be able to speak with you today to provide some more information about IPN, how and why it works. I've been with the Intervention Project for Nurses for 26 years and have seen a lot of change through the years, and want to share with you a little bit about how the program came about in the first place, how it's structured, why we exist, how we help nurses, and how we also work with the Board of Nursing. So the Intervention Project for Nurses is called an Alternative to Discipline program. Another name for that is diversion program, because these programs are in existence to divert the nurse away from disciplinary process. Florida is one of 46 states who have such alternative to discipline programs. We were actually the first state in the country to start an alternative to discipline program, and we're the largest program in the country. Part of that has to do with we have a lot of nurses in Florida. So how did the Florida IPN begin? Well, this movement started back in the 1980s. Actually, the American Nurses Association was key. It called out to the states to look at another way to assist nurses with problems. Health problems such as substance use disorders or mental health conditions, and to help them in a way that was an alternative to discipline. Because prior to the inception of these programs, the only option for employers and for the Board of Nursing was to discipline a nurse with substance use disorder or mental health condition that might affect their practice, and to either suspend their license or revoke their license. And that still happens today in some states that do not have an alternative to discipline program. So ANA called out to the states, and they called out to the states to do a few things. Educate people about such problems, initiate research and disseminate information, and to develop a non-punitive approach to help nurses. Let me share with you a little bit about the Florida experience. In the 1980s, the Florida Board of Nursing utilized a discipline-only model, which I just mentioned. The board began to recognize that substance-related cases were significant in number and reoccurring. And the only option that our Board of Nursing had at that time was discipline to remove nurses from practice. And they'd remove nurses from practice for an extended period of time, and then the nurse would come back to practice, and what they would find is, would come back for reinstatement of their license, and what they'd find is they'd reinstate it, and then there'd be more problems. So it was reoccurring problems because the nurses weren't treated and weren't monitored. Another concern at the time related to evaluations that nurses had done that they brought to the Board of Nursing. The evaluations often lacked sufficient uniformity in credentials and areas addressed, and also quality. So it was on October 1st, 1983 that legislation was passed to create an alternative to discipline program for nurses here in Florida. The Florida Nurses Association lobbied to get this legislation passed, and it was crucial, again, to set up this alternative to discipline. And Governor Bob Graham actually signed the legislation at that time. So an alternative to discipline, also known as a diversion program, was now approved in Florida after the legislation was passed in 1983, thus providing a new option for employers, treatment providers, nursing schools, nurses to refer and assist nurses who demonstrate signs of impairment in the workplace. We were initially called the Impaired Nurse Program, but realized that that would only create more stigma, so the name was changed to the Intervention Project for Nurses. We function under a contract with the Department of Health. So let's talk about the Nurse Practice Act and the requirements for reporting a nurse that may be demonstrating signs of impairment. And this is Florida Statute 464, is the Nurse Practice Act. And if we look at section .018 of the Nurse Practice Act, we're looking at grounds for disciplinary action. And I would suggest that you Google FS 464.018, and it'll show you exactly a laundry list of what are considered possible violations of the Nurse Practice Act and also grounds for disciplinary action. If you go on down the list, On K, it says, it's grounds for disciplinary action if a nurse fails to report to the department any person who the licensee knows is in violation of this part of the rules of the department. In other words, we have a mandatory reporting law here in Florida. If you as a licensee are aware of another nurse licensee, or any health care licensee for that matter, who's demonstrating signs of impairment, coming to work smelling of alcohol or pre-employment drug screen for an illegal drug or a legal drug without a prescription, these things are considered reportable. Now, prior to the intervention project for nurses coming into effect, this section here, the mandatory reporting law, stopped in the black. After our legislation was passed, the gold was added. And what does it say? It says it's grounds for discipline if you fail to report, but then they added, however, if the licensee verifies that such person is actively participating in a board-approved program for the treatment of a physical or mental condition, the licensee is required to report such person only to an impaired professionals consultant. What that basically is saying is now we have the option, if we're concerned about a licensee or a colleague, to refer them directly to IPN, we're the board-approved program, and that can be done in lieu of reporting them to the disciplinary Department of Health. So, let's talk about referring the nurse or making a report. A little bit about how this works. In this graphic, we'll show you. Over on the right is the disciplinary process. That was the only thing that was in place before '83. If an employer was concerned or someone was concerned about a nurse, they'd have to report them to the Department of Health. They would do a formal investigation. They have investigative offices all over the state, and they would assign the case or the concern to an investigator in the local area, who would go and interview the employer, identified nurse, colleagues, etc., look at documents to see if yes, indeed, there was a concern that was valid. They would then send that to the legal department in Tallahassee, where there's prosecuting attorneys. It's a large legal department. Then it would go to a probable cause panel, which is made up of board members. The board of nursing members at that time would review the case carefully in the probable cause panel to decide if there was or was not probable cause that the nurse had violated the Nurse Practice Act. If they find that no, there was no probable cause of a violation, they would close the case, and that would be the end of it. However, if they did find probable cause, it would then go into an administrative complaint, which would be sent to the nurse, which is a legal, several legal pages that tell them what their rights are at that point. And the administrative complaint would outline exactly what options the nurse had. The options such as a formal hearing, which is like a Perry Mason court with a judge, an informal hearing, which is to appear before the Board of Nursing in one of their regular meetings every other month in different parts of the state. Go in front of them and explain your situation, and they can look at the documents and ask questions. And then the outcome will be some form of disciplinary action. After the legislation was passed in 1983 to create IPN, it provided the additional option, which is on your left. Now, the same employer today could report the nurse who had a concern directly to IPN as the disciplinary alternative. We would receive a referral call in our intake office here at IPN. We would consult with the employer. We would talk with the identified nurse or whoever else was involved. We would then set up an evaluation with one of our approved providers who could evaluate the nurse carefully to decide what's going on and is there a problem or not? Is there any need for treatment, etc. If treatment's recommended, the nurse would then be helped with coordinating and accessing treatment, outpatient, inpatient, whatever the level may require. And then there would be a monitoring contract initiated, which most of you have. It can be anywhere from 1 2 to 5 years. Sometimes it's a 2-year with a 1-year review. That all has to do with what the diagnosis is and what the needs are of the individual nurse. To look at IPN mission, we have a very clear mission, and our primary purpose is to protect the public health and safety by providing education, monitoring, and support to nurses in the state of Florida. This program was initially funded and set up not only to assist nurses, but also a primary objective was to protect the public from unsafe practitioners or unsafe nurses. This just shows you a list of who can refer nurses to IPN. This slide shows you exactly who we service throughout the state. Nurses at every level, from student nurses to graduate to endorsements to LPNs, RNs, ARNPs to doctorate prepared. And we have several of the different levels of nursing who are currently under monitoring contracts. Some people ask me, what drives our policies? Is it just something that we come up with in the IPN office, or how do we get our specific policies and standards? Well, there's a variety of places that we look in the literature, and also are involved with professional organizations. The Substance Abuse Mental Health Service Administration out of Washington provides guidelines, white papers, etc. as far as substance abuse, substance use disorders, treatment, prevention, intervention, etc. The National Institute of Drug Addiction also has many documents that are evidence-based that look at these issues, and what they recommend is good care and follow-up. The National Council of State Boards of Nursing, which is the umbrella agency over all the boards of nursing, essentially looked at this over a several-year period and developed evidence-based national standards for monitoring programs. Our policies are also reviewed and approved every year by the Department of Health and the Florida Board of Nursing. And some of the policies that we have in place, such as our non-compliance policy, was actually a policy that came through the Department of Health to us. The International Nurses Society in Addiction is an organization that you may want to look into. It certifies nurses in addiction, either at the RN level or the ARNP level. And they also do a lot of research and evidence-based documents. And lastly, the American Society of Addiction Medicine. Our medical director, Dr. John Tanner, is on the board of ASAM, and we have all their documents, books, guidelines, etc. And these are the things that we base our policies on, so that they are sound and they are evidence-based. We receive referrals from a variety of sources. You can see some of you may have come into the program and been referred to us because of some of these reasons. It may have been a pre-employment drug screen for an illegal drug or a medication without a valid prescription. You may have had an accident at work and they did a for-cause drug screen on you and it was positive for an illegal substance or a medication without a valid prescription. Some nurses call on their own for help. There may be impairment secondary to prescribed medications, even if the medications are prescribed properly. But if the medications create impairment in the nurse in the workplace, it's a concern. Because the key thing that we want to look at is the nurse fit to practice? Are they safe to practice? And are they professional? Diversion cases are referred to us where medications are missing on the units, sometimes mental health instability, and physical conditions. We've had nurses referred to us because of unstable seizure disorders, multiple sclerosis, eating disorders, etc. Making a referral, basically this outlines what the employer does and how they call us and provide documentation to us. And also the employer's responsibility as far as if they talk to a nurse in the workplace who they're concerned about and the nurse is not willing to follow through and call IPN, then the employer is responsible for making that mandatory report. Just a couple things about substance use in the workplace, or substance use disorders. These disorders are progressive. They're chronic problems. Addiction is considered a primary illness, and it's considered a chronic illness. It has stages like any chronic illness. It has a course like any chronic illness. Early, middle, late stages, and sometimes too late stages. We've had, through the years that I've been here, many nurses who've actually died because of addiction. And it can be a fatal illness if not treated. And these were with accidental overdoses or suicides. But it doesn't just poof appear in the workplace. It usually is subtle, insidious, and progresses over time. And then once it reaches the level where it cannot be controlled anymore, there's loss of control, it spills over into the workplace. And it's usually been around for some time. A nurse who risks their livelihood and license because of substance use has loss of control and poor judgment, and it usually means that the person is using despite the chance of significant negative consequences. And these are a real concern and show that there is a significant issue going on. What are our goals for the nurse, and how do we help nurses? Well, we try to detect impairment early by educating employers and doing training, such as the fitness to perform training that we do all over the state. We want to do a thorough assessment with our approved providers and facilitation of the evaluation. We want to make sure that the nurse gets the appropriate treatment based on what the concern is. And then we want to make sure that we can do an individualized long-term monitoring plan, because the research shows clearly that nurses with substance use disorders who have substance dependence, a 5-year monitoring is what's recommended. And this is a national standard based on evidence that 5 years of good monitoring and progress in recovery, relapse rate just drops off, and it shows that most folks will do very well after 5 years of monitoring. And then of course we look at practice and safety. You're very aware as IPN participants of what we do to assist nurses in our program. Everything from processing calls, setting up appropriate treatment follow-up, your contract, reviewing quarterly evaluations, advocating for you with employers, with nurse support groups, etc. We talk, our case manager that you're assigned to, talk to your supervisor, review all the reports, set you up for the relapse prevention groups, schedule your screens, etc. Just a little word about treatment and why we decide on the treatment that we do. The National Institute of Drug Abuse has certain evidence-based principles of treatment. They basically say that no single treatment is appropriate for all individuals. That's why people in your group may have gone to various levels of treatment, may be different from your own. Treatment needs to be readily available. And we do know that with nurses, access is difficult sometimes because the nurse may have been fired, no longer has health care insurance, or has limited insurance. Treatment needs to attend to the multiple needs of the particular nurse. And remaining in treatment for an adequate period of time is critical for treatment effectiveness. So, people ask us all the time, how does alternative programs protect the public, which is one of our key admissions. So I want one of our key missions. So I want to just go over this briefly with you. If someone is referred to the Department of Health, in order for their case to be reviewed and go through the investigative, legal, and then come before the board, it can take anywhere, we say 9 months, but it's actually down to about 6 months now. Meanwhile, the nurse is out still practicing on a license while the disciplinary process is going on, and potentially unsafe. If someone's referred to IPN, a nurse is referred within 1 to 3 days. Refrained. And once they're refrained, the public is protected. We do comprehensive fitness to practice evaluations, comprehensive monitoring. We work with employers as a double safety net, and we identify relapse behaviors quicker than typical disciplinary process. So what do we believe are indicators of satisfactory progress in recovery and also safety to practice, which are things that we look at over time? Is the nurse adhering to their monitoring agreement advocacy contract? Are they providing negative random urine drug screens and other testing? Are they consistently attending their meetings and getting favorable reports? You're aware of the case management that we do. We're looking at your safety to practice, and we're also looking at your progress in recovery. You may wonder about why do we have practice restrictions in place, and this is something that is done in all programs throughout the country. It is a standard of care. We base it on the nurse's treatment, where they are in the recovery process, and also the monitoring program. In the early stages of return to work, there may be more restrictions, such as restricted access to controlled substances, need to work under direct supervision, and work in a setting that is structured rather than a non-supervised setting. But as the nurse moves through the process and goes into transitional monitoring, they have more autonomy and more options as far as employment. Returning to practice is not automatic. We have to make sure the nurse is safe and stable before they return to work. Specifically, the things that we look at and our evaluators look at in a return to practice evaluation are the nurse's stability and recovery, their support systems, problem-solving ability, cognitive and functioning, etc. The employer is very involved. Our case managers talk to employers on a daily basis about how the nurse is doing, how they're progressing. One thing that our participants voice as a concern to us sometimes about their employers or supervisors is they don't get enough feedback, positive feedback on an ongoing basis once they return to work. And in our trainings with supervisors, we encourage them to meet regularly with a nurse who's being monitored by IPN and back to work so they can get ongoing feedback. And any concerns can be addressed early. And I would encourage you to try to see if you can set up something with your supervisor too, so you can either ask for ongoing feedback or meet with them so that you can receive feedback on when you're doing well, when your performance is good, and also if there's any concerns that they have. As I mentioned, nurses that progress through IPN are on contracts of varying length. If there's a substance use disorder and a substance dependence, it's a 5-year contract, and this is evidence-based standard of care. Some of you may be monitored early if it's a substance abuse rather than dependence, if it's a mental health condition that doesn't require 5-year monitoring, but it's all done on an individual basis based on your needs. The majority of nurses that come into IPN do so as an alternative discipline. What does that mean? As long as the nurse comes into IPN and follows through and gets what they need and progresses in a safe to practice, they can successfully complete IPN without the Department of Health Board of Nursing being knowledgeable at all. It remains private information, non-public, confidential, and the record is sealed once the nurse successfully completes the program. We work carefully with the Board of Nursing and are present at their meetings. We don't share any documents or data or confidential information with the board unless a nurse is terminated from IPN. As nurses successfully go through the program, the Board of Nursing is not knowledgeable at all of your individual circumstances or case. We do training for the board and investigators. We're at each board meeting as consultants, etc. What happens if a nurse fails to adhere to their contract or fails to progress? Many of you know that we have a process of non-compliance, a non-compliance policy that we follow that was issued by the Department of Health. And we are required to turn the case over to the Department of Health if the nurse doesn't remain compliant doesn't follow through, does not communicate with us, etc. All those things that are outlined in your participant handbook. And if a nurse, such as a nurse case that I'm dealing with right now, where the nurse is trying to work, they relapse, they're not willing to go for an evaluation, they could be a potential threat to the public, I have the option of requesting consideration for emergency suspension order or emergency restriction order on the nurse's license, because we're concerned about an immediate threat to public safety. You may wonder about our outcomes. Well, we had to do a report recently for the Department of Health and look at how many nurses are employed in nursing that are monitored by IPN. They were concerned about the complaints that they were getting about the difficulty nurses finding jobs while being monitored. And this is true. There are concerns about nurses not being able to find employment, particularly in specific areas of the state. But when we did our full report, we found that 76 to 78% of our nurses who are currently monitored under IPN are employed in nursing while being monitored, which is, I think, very good. Our relapse rate, if you're curious, is 9%. What is our recidivism rate? This is based on nurses that successfully complete the program, how many come back in, and it's around 7%. They find that these programs contain costs and have cost benefit. And then lastly, I wanted to mention a study that IPN participants did in the University of Maryland, and Dr. Allison Trinkoff and Jeannie Geiger-Brown. They surveyed our participants and found that 4/5 of IPN participants saw significant improvement in all areas of their life upon completion of the program. The two areas that they didn't find the improvement, and we weren't surprised, and it's true today, is financial stress because of the costs of the program and sometimes not being able to work for extended period of time, which is very difficult on the nurse, and also stress level. So, it's the final slide. I'm glad I had an opportunity to speak with you today. If you have questions or anything that we can help you with, you can email me directly or call. Or once you look at this together and discuss it, if you need clarification, please let us know. Here's our website and our 1-800 number. And also for physicians, pharmacists, dentists, respiratory therapists, and all other licensed health professionals, you can call the Professional Resource Network, and this is their number and website. Thank you for listening.